We are presently overwhelmed with the response that we have been receiving for this particular webinar. Gayathri, you must be pleased to know that, and we have 100 participants. Wow. So you can understand how popular this topic is and how important it is to the optometrist.
As an optometrist, when we do refraction, we in and out come across non-strabismic anomalies or we come across squint. It's our responsibility and most of the management happens at a non-surgical level. So today's topic is actually an extension of helping you in your refractions and understanding this non-strabismic and the strabismic management of the patients.
And to introduce or to give a brief about Gayathri, she is well known in the field of binocular vision. She has great amount of teaching experience as well as clinical experience. She holds a master's in both clinical optometry as well as psychology. She owns the Bubble Eye Care Clinic at Noida, where she practices comprehensive optometry eye examinations along with vision therapy, which is her main forte. And she also handles children with special needs. I welcome Gayathri.
Today we'll be discussing 4 cases as a part of management of strabismus. These are basically the most common cases that we encounter in our practice. And we have in the previous lecture in the series, I had actually discussed about how we diagnose and how we evaluate. So in this, it will just be 4 case presentations, and with the case presentations, we'll discuss bit on the type of squint and how to manage it. So case 1, it was a 6-year-old male who came for a routine examination. The mother of the kid was an informant. She complained that the kid was restless and inattentive and at times often bumped into various things. And she also mentioned that the kid developed a eye turn, that is towards outside. So there was an exodeviation that she was seeing, and she was seeing it for the past 6 months, especially after the kid had developed a viral fever. On examination, his unaided visual acuity was 636 partial both eyes. The refraction was about -4 diopter cylinder in both eyes again. And on cover test, it was found that the kid is having intermittent exotropia, about 30 prism diopter, which was equal in for both distance and near. As a part of the management, the other examinations were also done for this kid, and the retina and the rest of the ocular examination was normal. As a part of management for the kid, what was done was, since the astigmatism was high, a full astigmatic prescription was given. And he was started with -4 at 180. Since he's a kid, he could tolerate the full prescription. And initially, we gave him just the prescription and reviewed him after some time. And after 12 weeks, when he came for review, his visual acuity had improved to about 6/9 partial. The stereopsis was 80 seconds of arc. The squint, though still there was a intermittent exotropia, but the control was better. Which here what I mean is that the frequency of the foria developing into atropia was less. So there was a better squint control. So in this particular case, what was basically done was we suggested that the kid go in for a Virgin's therapy, wherein we worked on the convergence of this kid. So mainly for intermittent exotropias, what is done as a treatment option is a first option should be to give a full correction for whatever refractive error that we get. Then we assess the squint again after the kid has used the glasses for a few weeks. And once we assess the squint again, depending on the variation, if it is still intermittent, then what we do is we just go in for vision therapy. There is no need to prescribe prisms. There is no need for going in for surgery when it comes to intermittent exotropia. So the best mode of treatment for these kind of intermittent exotropias are Virgin's therapy, where you work on their posterior fusional Virgin's amplitudes, and we also work on their Virgin's facilities. So initially we work mainly on the posterior fusional Virgins or their convergence amplitudes, And later on, we try and increase the fusional vergence range. That is, we work on both the convergence and divergence part and also their vergence facility. So this is when it comes to intermittent exotropias, because I generally see people when it comes to intermittent exo, they either are suggested for surgery or you go in to prescribe prisms, both of which are not needed. And the best mode for intermittent exos is to go in for vision therapy. Now, in case 2, it is a case of a 1-year-old baby. Here, the parents complained of eye turning in for past 6 months, and the cycloplegic refraction of the kid was plus 150, both the eyes. On cover test, it was found that there was a 45 prism diopters of ESO, which was there equal for both distance and near. And on the fixation, when tested, the right eye fixation was central and unsteady. For the left eye, it was central and steady. Rest of the examination for this kid was nothing significant was there. And to talk of the birth history of this kid, everything was normal. It was a full-term baby, and there were no developmental delays, and the initial developmental period of the kid was also normal. Now, this particular case wherein there is a ESO deviation that is seen within 6 months of the kid's birth, that is essentially coming under the category of essential infantile esotropia, wherein you generally see tropias of the range of 30 diopters and more. And this is the first occurrence of the squint starts at about 6 months of period or before that actually. And generally it is like after about 4 months of age, if you see a esotropia and which is like of large deviation and it remains constant, then you should consider in terms of a essential infantile esotropia. In essential infantile esotropia, again, the management option is to give, if any cycloplegic, if any refractive error is present, you give the full cycloplegic refraction that you get. If there is any amblyopia that you see, then you treat it. But at that age, it just depends on the fixation preference that you will see when you occlude, that you can decide whether there is any preference to any eye that you can see. Surgery is usually the option indicated in essential infantile esotropias, and it is done best, the outcomes are best when it is done at the earliest. So typically once the squint, the amount of deviation is sort of settled and it is confirmed that it is an essential infantile esotropia, and the amount of, you're able to completely correctly figure out the amount of prisms, then you can the surgery is the best option in this case. And once advised, it is generally done before 2 years of age for the best outcomes. In this, there is one more thing. There are at times chances of a AV pattern also to be seen. So when before the surgery is done, number one is that the amount of prisms has to be correctly identified. Second, it has also to be identified whether there is a or a V pattern associated over here, in which case both of these are corrected at the time of the surgery. The next case is in a 5-year-old male. He presented with squint in the right eye for past 1 year. They have been seeing there is a squint, and this was primarily noted down during the lockdown period. And the kid was also complaining occasionally about headaches. The kid had the general health of the kid was good, and there was no significant birth or family history. And there was no developmental delay that was reported by the parents as well. On examination, what was found was there was the cycloplegic refraction was about plus 5.5 diopters sphere in both the eyes. On cover test, it was found that there is 30 prism diopters of esotropia, which was alternating. Again, the esotropia here is equal between the distance and near. And with the correction of about +5, the tropia came down to an esophoria of 5 prism diopters. From 30 prism diopters esotropia, it came down to esophoria. Rest of the examination was sort of within normal limits. Management here, this particular case wherein the tropia comes down to phoria, it is indicative, and since it is the tropia is equal for both distance and near, it is indicative of a refractive accommodative esotropia. And here it is enough if you just prescribe the full cycloplegic prescription, and then you do a follow-up after 3 to 4 weeks for again for squint evaluation, primarily because it takes some time for the squint to settle down after the prescription. So you give a full cycloplegic prescription and wait for and do a follow-up after 3 to 4 weeks. And here what is important is you need to educate the parent about the importance of constant wear of glasses, because most of the squint of this child from manifest, it comes down to latent squint just by usage of glasses. And hence it is very important that you stress this particular point to the parent, that they need to ensure that the child is wearing glasses at all times. Since the kid is of a young age and they have enough amplitude of accommodation, they may see clearly even without the glasses, right? So there would be a tendency for the child to not wear the glasses unless they are forced to, or the parents ensure that the child starts wearing the glasses. And at this age, typically they respond well to the glasses. Now, in the same case, in the similar case of esotropias, there is another scenario which comes in, wherein there are kids who come in who have a difference between the distance and the neotropias. So in this particular scenario, the case remains the same. I've just added a difference, wherein on cover test, the child has 30 prism diopter esotropia for distance, whereas for near, the esotropia increases to about 50 prism diopters. And when you give a near addition to this child, then the neotropia reduces to about 5 to 6 diopters esotropia. So this is a typical case of wherein there is an accommodative component involved, wherein there is high ACA ratio that is present. Because of the high ACA ratio, the near esotropia increases considerably as opposed to the distance. And this also differentiates this from the regular refractive accommodative esotropia, because the refractive esotropia generally has distance equal to the neotropias when the ACA ratio is normal. Now we'll just go into a bit on what are the characteristics of the various esotropias that we see. In accommodative esotropia, which is typically acquired, which means that unlike essential esotropia, you tend to see this after 1 to 2 years of age. So generally the onset is at around 2 to 3 years of age, and it is intermittent to start with, and slowly it becomes constant over time. There is usually an associated amblyopia, and this is often hereditary, which means there will be someone in the family who has had a similar complaint. The power is the amount of tropia is generally about 10 to 35 prism diopters. It is moderate, and the angle generally tends to vary, and it is more at near. Depending on the esotropia, the ESO at near might be larger than the esotropia that is found at the distance. And the types of accommodative esotropia that we usually see, I'm just talking of the comitant variant here. Here it is the refractive kind, wherein you have high hyperopia and normal ACA ratio. You have non-refractive kinds, wherein there is no or very little hyperopia, but there is a very high ACA ratio. You then have a hypoaccommodative hypoaccommodative type esotropia, and a mixed or a partial accommodative esotropia. So if we look at the refractive accommodative esotropia, the amount of this particular ESO varies depending on the amount of hyperopia that is there. And usually when you give a full cycloplegic correction for the refractive error, it reduces or eliminates the esotropia completely in all directions. And you just either get an ortho or you just get some amount of esophoria that is present. And this usually starts at about 2 to 3 years of age. And to start with, initially it is intermittent and then goes on to become a constant esotropia. It is about 20 to 30 diopters, and usually it is unilateral but can be alternating as well. Distance and neotropias are almost the same. It will be within the range of 10 prism diopters, and the hyperopia in this particular type usually ranges between plus to 6 diopter. Depending on whether it is alternating or not, you may tend to see suppression and ARC, and there is chances of a AV pattern to be associated along with this kind of squint. The management for this type of squint, as we discussed with the case, is to provide full cycloplegic refraction, whatever value you get, and again that will depend on the age of the kid. And generally for esotropia in many kids, it is seen as an immediate result, wherein the moment you give the glasses, you can see the tropia come down. But in some, you don't see that. So once they start wearing the glasses for some time, you can tend to see the difference in the tropia value. And hence, it is always good to do a review after 2-3 weeks of wearing the glasses. And usually, these kids have to wear these glasses on a full-time basis. Now, for infants below 6 months, they usually have non-accommodative infantile esotropia. That is the essential infantile esotropia that we discussed earlier. But we need to, in this case, rule out whether an accommodative component is present. So generally, before we can conclude whether an accommodative component is present or not, you give whatever prescription or a refractive error that you get, full cycloplegic refraction that you get, and plus you give a added 1.5. The added 1.5 you give because at this age, most of the work that they do is at near. So if it is an accommodative type, then giving that near added addition will stop them from using added accommodation, and that will help reduce the ESO a little bit. So that is why you give a near addition. 1.5 you can give a 2 or a 3 as well, depending on how much it helps to reduce the ESO. And after 3 weeks, you check the deviation and repeat the refraction. If there is any hyperopia that is added, that you find in the next review visit, you give it. If it is the same, what I mean, if it is the same is that if the tropia, esotropia, the amount of deviation still remains the same with the use of the glasses, then it is indicative that this particular ESO is an essential infantile esotropia, and there is no amount of accommodation that is involved in this particular case. And that is why this will be classified as an essential infantile esotropia, wherein this management will be a surgical intervention. If for 6 months to 6 years of age, you again prescribe a full cycloplegic refraction, and for a kid who is less than 1 year, you will tend to do a review visit every month and till the tropia stabilizes. For a kid above 1 year, you will review and repeat the retinoscopy and your cycloplegic refraction after every 6 months. For kids above 6 years of age, you generally tend to push maximum plus that provides fusion and good visual acuity. And you do a follow-up every 6 months for the next 2 years, and then you can do an annual checkup. But typically, it tends to reduce the amount of tropia and the plus that they need. So that is why you need to do a follow-up visit at 6 months' time frequently. And if there is any amblyopia, you provide amblyopia therapy that goes simultaneously side by side, and you also do your anti-suppression exercises to improve your negative fusional vergence so that you improve their fusional vergence ranges. And again, here, so for accommodative type of esotropia, surgery is not recommended until there is a vertical component or a AV pattern that is associated with it. And when the surgery is done, typically it is done only for that part. The rest is managed with the refraction or the plus lenses and the bifocals that you will give. Then is the non-refractive accommodative esotropia. Here, the accommodative part is the reason why you see the esotropia, which is more at near than at distance. That is mainly because there is a high ACA ratio. The refractive error is very minimal and it has nothing to do with the esotropia that you see. And typically in these cases, you see a normal near point of accommodation. The reason I mentioned a normal near point of accommodation is because this will help you differentiate this with a hypoaccommodative esotropia, where in hypoaccommodative esotropia, you have a reduced near point of accommodation. The management here is you give again full cycloplegic refraction, plus you give a near add, which is a +3, a +2, whichever that will bring the least power, which will bring the eyes together and will regain fusion. And you give that as a prescription to the child. For kids less than 6 months of age, no bifocal is given. It is just a single vision glasses which is given, which will be the full cyclo plus an addition of 150 diopter spherical. So that will be a prescription that will be given for kids. For people above 6 months of age, you will give a pupil bisecting executive bifocal. And for both of these cases, you will do a follow-up every 6 months for the next 2 years. And then it will be an annual checkup. Here, the ad that you give for the near part will actually vary, though I have put in as a +3 depending on the distance that we are using, but it will usually vary. It will be the least amount of plus that will bring the eyes either straight or where you regain fusion. The ad power can be reduced to 0.75 to 1 in older kids so that you get a fusion response. Again, here you will need to give Vergence exercises to improve their divergence amplitudes. So you start with improving their negative fusional Vergence ranges. You also work on their facility, and once you are able to improve the ranges, you then go on to improving both the positive and the negative Vergence ranges. If the esotropia doesn't respond well to the use of bifocals, only then should you consider a surgical intervention in case of accommodative esotropia with high ACA ratio. In hypoaccommodative types, the esotropia again, like we saw in the accommodative type, the near deviation is greater than the distance deviation. Here, but there is a weak near point of accommodation. In the earlier case, the near point of accommodation or the amplitude of accommodation was normal. In this case, it is reduced, and hence even your ACA ratio is normal to low. This again is nothing, it's not related to the amount of uncorrected hyperopia that is present. The management here will again be a near addition, plus you will have to do vision therapy to improve their amplitude of accommodation and the accommodative facility. So the vision therapy will aim towards improving both your amplitudes and your accommodative facilities. So this was till now we talked about intermittent exotropia. We worked on esotropia, primarily the accommodative esotropias and the essential infantile esotropias, because these are the 3 cases that you usually encounter. The next is again a case that we encounter, and this was a case that I encountered that I saw during my internship period. She was a girl, 6-year-old girl, and she had difficulty moving the left eye outwards. And this, the mother was seeing for the past 1 year. So her general health and ocular health otherwise where there was nothing that was detected, and she didn't have any known drug allergies. Her birth history was normal and her developmental history was mostly normal. And there was no history of consanguinity in the family. On examination, her vision was 6/6 and 6 both eyes. There was no refractive error that was found. Most of her accommodative and Virgin's parameters came out to be normal. Cover test was again ortho for distance and near. But when we did her eye movements, we checked her eye movements, there was an absence of abduction in the left eye, and there was a limited adduction in the left eye. There was globe retraction and narrowing of palpebral fissure, which was seen on adduction. This was the case wherein when she was looking on to the right, there was a limitation of adduction, and you can see that the globe was retracting in. In primary position, there was a small head tilt, but then otherwise it was ortho that was seen. And when she was looking towards the left side, on lever version, there was an absence of abduction that was seen in the left eye. So this is a typical case of Duane's retraction syndrome type 1. In type 1, generally we have a limited abduction of the eye which is affected. And usually you see a ESO in primary position. You may or may not see a ESO in primary position as well. So in this particular case, the management or the basic idea was to educate the kid, the patient and the parents about Duane's retraction syndrome. There was no treatment advised because the kid as such did not have any deviation in the primary position. There was a little bit of head tilt, but it was not significant enough, and it was not cosmetically or in any way bothering the child. So that is why there was no treatment or surgery that was advised for this particular kid. Just to go and discuss a bit about Duane's retraction syndrome. In this particular syndrome, you have 3 types, type 1, type 2, and type 3. In type 1, there is a marked limitation that is seen in abduction, which is normal or slightly defective, and there is normal or slightly defective adduction that is seen. ESO deviation may be present in primary position, but as was seen in this case, there was no ESO deviation. It was an ortho in the primary position. Generally, there is a narrowing of palpebral fissure which is seen on adduction, and a widening of palpebral fissure which is done when they try and force abduction. Globe retraction is another feature which is seen in your adduction case. And when you talk of Duane's retraction, type 1 is the most common type that is usually seen.
The first step towards achieving your dreams is having the right coach. Get the best education with Learn Beyond Vision and make your optometry dreams come true. Download the app now.